بسم الله الرحمن الرحيم. جزيل الشكر للجنة المنظمة لجمعية الإسوارز، وجزيل الشكر للأستاذ الدكتور نادر بيومي على الدعوة الكريمة. My talk is about cataract after glaucoma procedures, either laser incisional surgery. وطبعا it's some sort of a challenge to put glaucoma beside refractive, and I hope we have some people interested in this talk. Why this topic matters? أول حاجة, we should know that the cataract risk increases in the first 5 years after trabeculectomy, and in some cases there is some coexistent already between cataract and glaucoma, and very early cataract appears with glaucoma, and it increases more in density with time. And should be mentioned that the faster progression of the cataract can be associated with filtering surgery. Why also this topic matters? Because glaucoma surgery increases cataract surgery complexity. There is now high refractive expectations of the patient, and after cataract surgery, and the glaucoma surgery will hinder some or give some difficulties in such a situation. And also what we should tell cataract surgeon to take care about when they are dealing with a case of cataract and previous glaucoma surgery. First, why do glaucoma procedure accelerates cataract? Some mechanisms are present. First is the inflammation, because inflammation disrupts lens epithelial homeostasis, so it can accelerate the nuclear sclerosis. Also, the hypotony, if present, can alter aqueous flow and can impair lens nutrition and can impair metabolic exchange. Also, if you have shallow EC postoperatively after cataract, the direct trauma to the lens can induce cataract. And also, if you have aqueous misdirection, it can further complicate the situation. Even in glaucoma surgery, we are using steroids, and we can prolong the use of steroid, which can lead to complications like posterior subcapsular cataract. Also, is cataract can develop after laser procedures? It depends on the type of laser used. If we can use SLT or selective laser trabeculoplasty, we actually use sub-threshold energy. So there is minimal lens exposure, and there is no risk of increasing or developing the cataract with the SLT. On the other hand, if you are using laser peripheral iridotomy, you can use direct energy to the lens. This is rare, but is documented to do anterior capsule injury or can do capsular damage, especially if you have shallow EC or myotic pupil. And in the CPC or diode laser cyclophotocoagulation, here you can do direct destruction of the ciliary body. You can have intense inflammation and hypotony, and this is the highest cataractogenic risk among the laser modalities. What we should tell in cataract surgery after trabeculectomy, we should mention that the subsequent phaco surgery can risk the bleb failure. Also, you can have shallow EC after the cataract surgery. You should do temporal clear corneal incision to preserve the bleb. We should have meticulous wound construction, and you may suture your wound at the end of the surgery in some cases. If we are dealing with a case of cataract after tube or shunt, like Ahmed valve, Parveld valve, or even Multino, we should mention that we have in these cases altered anatomy, especially of the superior temporal or the superior conjunctiva, and this can limit the access of the incision, and we should take care of this during construction of our incision. Also, if you have tube lens proximity, if you have the tube near the lens, this can lead to direct injury of the crystalline lens or can make some difficulty during the surgery. Also, if we have tube and near the cornea, you should take care of the endothelial cell loss, and which can accelerate this endothelial cell loss during cataract surgery. if we have synechia formation, either peripheral anterior synechia or posterior synechia, this can do restriction in pupil dilatation. So, what are the checklists to revise before entering to do a cataract surgery for a glaucoma patient or a patient who had undergone glaucoma surgery before? First, we can check for pleb function and IOP control. Then the tube position, if you have a tube, the presence or absence of peripheral anterior synechia or posterior synechia, the zonular status and the endothelial reserve of the patient, the anterior chamber depth, and finally is the target refraction we are aiming at. First is the pleb function and IOP control. You should talk to your patient and discuss with him well if he may need to go for combined surgery, if he has uncontrolled intraocular pressure. We should tell him about the incidence of pleb failure after cataract surgery. We can use slit lamp assessment as regard the pleb height. Even you can use anterior segment OCT for the vascularity and functionality. It can be helpful. Then, if you have synechia, zonular dialysis or low endothelial reserve, we should know this well before entering to the surgery to prepare our tools. What are the tools we need to prepare if I have synechia or narrow pupil? It is advisable to have cohesive viscoelastic like Halon GV to make the anterior chamber deeper and can dilate the pupil. Even I can use mechanical stretch if I can prepare iris push-pull or something like this. If I like to do mechanical stretch. If I have to use iris retractors, I should prepare them. And even if I need to get a pupil expander ring. Also, to check for the zonular status, I have to dilate the patient well and can see this dialysis if present with the high magnification and retro illumination. So if I can see this, I should prepare myself by my tools like using viscoelastic to make tamponading for the prevention of vitreous loss through this dialysis. Also, I should prepare either Sioni ring or CTR or even Sioni ring segment, or prepare myself for doing scleral fixation IOL. Also, to check for the endothelial reserve of the patient. As we mentioned before, if I have tube which is near to the cornea, I can check the position. If I can see the tube well, I may use UBM if needed. Also, I should do specular microscopy for these patients mandatory to exclude endothelial cell loss, even if I have cell count below 1500s or less. I should have extreme caution. It's advisable in such cases to use highly dispersive viscoelastic to protect the corneal endothelium, or even use the soft shell technique with combining cohesive and dispersive viscoelastics. Also, it's advisable to use low phaco power setting and low phaco parameters to avoid turbulence inside the anterior chamber. As regard cases with shallow AC, they can be encountered in cases with small axial lenses, as we mentioned before, also in post-trabeculectomy hypotony, or in cases of aqueous misdirection. We should know this and prepare our tools like high viscosity cohesive viscoelastics, and we should take care for the endothelium. And there is another tool which is important and can be very helpful to enter the anterior chamber in such cases with shallow AC. If we have a trocar into the vitreous cavity and the 23 gauge vitrector to decrease the vitreous pressure and can increase the depth of the anterior chamber and make me can reach the anterior chamber with protection of the corneal endothelium from direct trauma. Lastly and not least is the refractive consideration and IOL strategy. This scheme is can be made for the glaucoma status, and the IOL strategy we may recommend. If we have mild form of glaucoma with patient with well-controlled glaucoma, we may use the premium IOLs. If they have stable cornea, we may use toric lenses, but we should discuss with the patient his to be in realistic expectations to avoid high expectation in such patient. If we have moderately uncontrolled glaucoma, or if we have a pleb or previous trabeculectomy, we prefer to use monofocal lenses because the pleb-induced regular astigmatism can limit the toric predictability. Also, if we have severe or advanced cases of glaucoma, the reduced contrast sensitivity in such cases can make us to recommend monofocal lenses and better to avoid the multifocal. Also, if we have a tube or shunt in situ, the monofocal lenses is recommended, especially if we have endothelial cell damage or low endothelial cell count. And we should consider cases in such cases to consider the total keratometry in biometry. As regard the post-operative care and the intraocular pressure of these cases post-operatively after cataract, we may early have high early spike of intraocular pressure. This can be due to retained OVD. We may have this due to steroid response because all the patients of glaucoma are steroid responders, as you know, or even trabecular inflammation. We may have pleb failure, as we said before. In such cases, phaco can induce inflammation and promote episcleral fibrosis, so we may consider needling of these plebs using 5-fluorouracil or any other mode. We can maintain prolonged and meticulous steroid tapering in such cases. Also, if we have tube in place, we may have tube obstruction, and this can lead to high elevation of intraocular pressure. Vitreous can obstruct the tube, lens material can obstruct the tube, vitreous strands even or fibrin can occlude these tubes. We can use YAG laser to this tube. Also, we may need anterior vitrectomy to remove the vitreous. And in some cases, we may have chronic hypotony, which is due to overfiltration of the pleb, and may the phaco cause injury to the pleb or the conjunctiva. We may have persistent hypotony maculopathy. In some cases like this, we may need to inject autologous blood to induce more fibrosis to decrease chronic hypotony. Then, to conclude or summarize, we should remember that cataract surgery does not simply follow glaucoma surgery. It challenges every element of intraocular pressure achieved. So we have to plan for it. We need to protect our plebs, manage the tube, and optimize our refraction. Thank you.
Thank you very much for this excellent talk. One very simple question. Do you have any recommendations for doing the step of the capsulorhexis in a hypotenuse eye after glaucoma surgery?
The capsulorhexis is slightly difficult in such situation, especially if we have zonular dehiscence. In such cases, we may use high viscosity viscoelastic. If I have leaking pleb or over-filtering pleb, I may try to suture it before, or even before entering the surgery. I may need to manage the hypotony first. If I cannot manage, I can suture it, overlay suture during the surgery. I can use high viscosity viscoelastic. If the lens capsule is stretchy or not easy, I can use stain by Trypan blue or something like this. Okay. It can make the capsule slightly more easy to cut.
So the tip is to try to pressurize the globe as much as possible.
Yes.
Thank you very much, Dr. Mohamed.